West Suffolk Hospital, and my specialism is older people. So my talk is sort of mainly coming from the point of view of the older person with dementia, but I think a lot of the things can relate to anyone, and also can relate to people with what Lyndon termed as medical kleptomania, or comorbidities, or people with multiple health conditions, whether you have dementia or not. When I started to prepare for this talk, I looked at the brief that Louise mentioned this morning about the road less rocky and the survey and the information that had come from that. And the part where it says about the person with dementia has other health problems, the things that carers were saying that they wanted to know about, or that they wanted, was recognition of the role carers play in undertaking day-to-day healthcare tasks, and advice and training in undertaking these. They wanted to know about good routine healthcare for the person with dementia, and a more holistic approach to assessment and treatment, which take account of both their physical health needs and their dementia. And they also wanted information, advice and advocacy for carers who think the person with dementia may be eligible for NHS continuing care funding. So I will touch on all of these things, as these are the bits that were in the survey. But I'm just going to sort of go back to what do we mean by other health conditions. You've got dementia and other health conditions. So when I was looking at that, I was thinking people will probably have or may have a health condition that was present before the dementia was diagnosed. And by health condition, I'm thinking of things like long-term conditions, maybe asthma, diabetes, heart failure, any of these things that we're going to have for the rest of our life that have been diagnosed. And they may be present before the person had received their dementia diagnosis. Then there are health conditions that become apparent after diagnosis. So these may be things that creep up afterwards. And then there are also health conditions that occur because of dementia. So the dementia may precipitate these health conditions. So taking those things, so then sort of split it into those that were present before, what would the issues be for a person who's now received a diagnosis of dementia and they're also living with other health conditions? So in the initial stages, they'll probably still be able to manage their own health. If they've had these conditions for a while, they will have their own routine. They will have their own way of monitoring their conditions. They've got diabetes, they'll be used to taking their own blood sugars. So they may just need a little bit of support to carry on doing that, but it will be part of their life and they will be used to doing it. So it's important not to interfere too early, to give them their independence, to let them keep their self-esteem that they can manage their own health. But as the dementia progresses, they may need more help to do this. They might need simple things like memory joggers. I mean, how many people have a phone with apps on? How many have a diary? Do we use post-it notes to remember things? I've got my notes here so I can remember what I've got to say to you. We all use, ways of remembering. So it might be that, simple things that can be used to just jog their memory about when they need to take their medication, when they need to do their blood sugar, might be all they need in the early stages. If the disease comes after a diagnosis of dementia, depending on how far through their dementia journey they are, they may not recognise that their health has changed. And this is sometimes where sort of difficulties occur. Things like routine health screening are still important. We still need to look for those things that occur to any of us. Just because you've got dementia is not going to rule you out from treatment, so we still need to do our routine sort of health screening. There could be a transient illness that somebody has, and it could be treatable, but they may not recognise that they're feeling ill. And these transient things could become a chronic illness, so it could then become something that needs more long-term management. When people are going for tests, things like that, there may be difficulty with them understanding what's needed of them. Debbie was saying when she was taking her husband for his driving test, He got very angry with her. If people aren't understanding why they've got to go to the hospital, why they've got to go to the GP, if they don't feel unwell, why are you taking me here? So there could be a lot of, anger about why we're taking control of somebody. So getting people to attend appointments might be difficult. Remembering instructions. If you've gone in to see your GP and they've given you a list of things that you need to do, or maybe you need to go for another blood test and things, remembering all of those things if you're on your own is bad enough, but if you've got memory problems added to that, may be more difficult. So they might need somebody to go with them. With illnesses that occur after diagnosis, dependent on how severe the dementia is, the dementia might actually be masking a new illness. So as the person who is maybe closest to them as a carer, it might be you who first spots that some things aren't quite right. Many serious conditions might be accompanied by infection, by fever, pain, and these can all cause acute confusion, so a confusion that comes on quite suddenly could be causing them agitation. This is kind of a term that we call delirium, and you may well come across it if you come sort of, in healthcare we see it quite a lot in the hospital, and it's an acute confusional state, and it could well be not related to dementia. But somebody said earlier, I think it was Maggie said, if her mum went into hospital in an acute confused stage, she may well get the label of dementia. But what can happen is you can get delirium on top of your dementia. So you can have your normal level of memory issues, become acutely unwell, and become more confused than you would be normally. So as healthcare professionals, we're very reliant on carers and the people who know the person with dementia to tell us that this is not their normal, this is not what they are normally like, so that we can gauge, that they actually may be quite ill and we need to do, something else about this. Dementia might also complicate other health conditions. For example, if you've got cataracts, and can't see very well, if you've also got dementia, it might add to your sense of confusion. If you can't see where you're going, you already feel, that bit vulnerable, and if you've already got dementia as well, it's probably going to add to that. Hearing problems as well, you start to feel isolated, and then if you can't make sense of your environment, you're going to feel, very vulnerable. Some of the things that carers also have said, and it's in the report, about dilemmas around whether to tell the person with dementia a new diagnosis. If you suspected that there's maybe an underlying cancer or something like that, do you go through all of that treatment and then how do you tell them about it? And it's not something that I can perhaps answer here, but it's something you need to talk to with other healthcare professional who was looking after that person at the time, whether they need to actually know, will they remember that they've got this diagnosis, or is it just more important that they're receiving the treatment and they're being reassured through the treatment? And then we go on to things that are present perhaps because they have dementia. So I'm thinking more maybe in the later stages of the disease, where people are maybe more susceptible to urinary tract infections, to falls, to pneumonia, maybe malnutrition, dehydration, all of those things. So they're not conditions that occur exclusively to people with dementia, but they may be more at risk of getting these. And often they can be treated successfully, and so we need to be, aware that they're there. And again, you are the eyes and the ears of that person, and you're the one who can recognise that actually things aren't going so well. You might think actually they're not eating all their meals. They had a good appetite last week, this week they're not eating so much, or they don't seem to be drinking quite so much. Why aren't they drinking? And start to sort of, have these little warning bells that things might not be quite so good. So I've said that these things can be treated sort of in the early stages of dementia. However, towards the end stage, they may indicate kind of a general decline in their condition. We've touched on things like advanced care planning, and that may be the time when people want to consider, certainly in Suffolk we have a yellow folder where people can write down what their wishes are for their care, what they would like to be treated, what they don't want to be treated. So along those lines, it might be some time, that you might want to start thinking about that things are progressing. So what are the consequences of other health conditions alongside? As with the general population, any health condition that are not monitored or treated in the right way will have an adverse impact on somebody's quality of life. So we need to try and keep people well, keep them monitored, keep them up to date with their medications, and do all those things. For someone living with dementia, they may be at an increased risk because they might not be able to tell us that they've got any health changes. So it may need to lead to a late diagnosis or delayed treatment. Conditions that were once stable may become an issue if the person living with dementia forgets to take their medications or doesn't attend for clinic appointments, all of those types of things. But getting somebody to attend clinics might be an issue. Can they travel? Do they like going out somewhere different, a strange environment? I work in a hospital, I'm still not particularly keen on going for clinic appointments for myself or family. You always feel that bit nervous. If you don't actually understand why you're going there in the first place, you may not feel unwell, but somebody's sort of saying, you must go. Why do I want to go? I'd rather go out in the garden, thank you very much. So all of those things are issues for carers to get people there. As the dementia progresses, carers may need to be more proactive in managing the person with dementia's health. So that's when you start to take on board, making sure they're taking their medications, making sure they're drinking, making sure they're eating. So you're thinking for two people. You're kind of constantly thinking about, this other person as well, making sure they've got everything they need. And if you don't live with them, it could be a son or a daughter, it could just be a family friend that you're looking after. Added stresses because you, as you said, running two households, and trying to keep everyone happy. An acute episode of illness might lead to a marked decline in the dementia. So if somebody comes into hospital with, say, pneumonia, that's treatable and we can do that, but actually their cognition might decline while they're in hospital. It may be because they're in a strange environment and when they get home, actually they pick up again, but it may also be that they don't recover back to where they were before. So points for carers. Maintain a person's independence for as long as possible, but you have to balance that with keeping them well. You may be the person who notices changes, so look for signs, things like increased confusion, increased drowsiness, not drinking or eating as much as normal. They might be falling, they might start to fall where they weren't falling before, or they might be falling more frequently. They might be passing urine more often, and there might be a smell with it. And if any of those things trigger, then alert your GP or let your GP know. They may be signs of an underlying illness, but it may be that the person can't tell you about it. As I said, as the dementia advances, you may become more responsible. For long-term conditions, it might fall to you to, say, monitor blood sugars and things like this, ensure they're taking medications. But it might be that you don't want to do these things. So if you can let people know that what you are happy to do, because it may be that you might be dealing with equipment, catheters maybe later on, it could be anything. If you're not happy to do that, then just let your GP know, because there are other people who can do it in their own home with you, watching, supervising, whatever you want to do. So it has to be where you're comfortable. And it might be, I think it might have been Louise saying earlier, she didn't want her family giving her personal care. She would rather have a carer come and do that. So it might be the person with dementia's preferences as well. They might not want you to be doing these things for them, but they might be happy for somebody that they don't know so well to do it. When the person with dementia loses capacity, and Nigel spoke very well on this earlier, you may be involved in making health decisions for that person. So then you have to start thinking, what would they like? What would be their wishes? And so all the things that Nigel spoke about earlier are things to take into account. Make sure you've got those documents ready, that you can make those decisions if you need to. If you're not happy making those decisions, who will be doing that for them. If you do have to go to any appointments, try writing a list of things that you'd like to know about. I know when I get into an appointment, you get flustered, you've got 10 minutes, time starts now, and by the time you've got the person settled and you start to talk, things have gone out of your hands. So have a list of things that you would like to discuss, things that may have been occurring, may have started to go wrong, or things that you found, helpful even. Just have a list of things that you want to discuss. It's your appointment with the person, and you need to, be in charge of that. If you can, let the clinic know that the person you're attending with has dementia, because they will try, if they can, to make that clinic time or that appointment less stressful for you. If they know that the person doesn't want to sit still, will be anxious to get home, doesn't like being in a strange place, they will try and get you through the appointment quicker so that you don't have all of those anxieties as well. Something that Nigel sent to me during the week, or to Maggie during the week, was about people with dementia often feel excluded. So even though a consultation might be about them, we tend to answer for them and might jump in quite quickly with answers. But it's about maybe slowing down, letting them have time to answer a question that's been asked them. Try not to talk over them, and try not to point out mistakes or correct them or interrupt them, and certainly not excluding them. It should be a partnership. This is their health, it's their issues, and while you might be the carer and you might have all the responsibilities for sorting it, they still need to feel that this is about them. And any health professional worth their salt will take on board your views as well. So even if they're saying things that are not right, there will be time for you to add in those corrections in the consultation. So things that you can do. Keep yourself healthy. We've talked about, well-being for carers, so keep yourself healthy. And also the person that you're caring for. So things like the Alzheimer's Society do very good leaflets about staying healthy. And it's things you can do with the person. So going for walks, especially in the early stages, keeping mobile, getting fresh air will help you sleep better, giving you some activity, those types of things. So healthy diet, rest, make sure you keep up to date with health screening for the person with dementia, attending flu clinics, all those types of things, and seeing if you can get access to respite care. I know that's like kind of gold dust. Toby's looking at me. We try, yeah. Just keep badgering people because, unless people... Yeah. So in the early stages, using memory joggers so that, people can try and keep on top of their own health. But then, as you may not even realise you're doing it, but you will end up taking over some of the healthcare things. But it's about, how comfortable you are with that. If people are started on any new medications, I know we had a session about medications, but it could be a medication to do with their other health condition and not with their dementia. But sometimes they can have an adverse effect, or they might interact with the current medication. So it's about looking out for increased confusion, again, increased falls, drowsiness, anything that you think this isn't quite their normal. What's happened? What's different? Oh yeah, we started a new tablet last week. Is it that? Because only just a small dose of something can have quite a detrimental effect on some people if it's not the tablet for them. And just monitor how they're going with their regular medications. If you don't live with a person and they're taking their own medications, just sort of check every so often, are they taking them at the right time? Do they need things like a dossett box to help them? They're not always the answer because people don't always know what day it is, so do they know whether they're taking Tuesdays or Wednesdays? Does it really matter? They kind of like think, well, I've taken some tablets, I don't really know whether they're the right ones or not. Check that they can still swallow them, especially in sort of the later stages of the disease. Swallowing is a problem. A lot of medications can come as a liquid form. So just ask if you can have medications as a liquid form. Don't keep persevering, putting them in yogurt, whatever you need to do to try and get them to take them. Just ask if there's a liquid form, and if you just need to change them. Let your GP know if there are any issues. And also get your medications reviewed quite often. We see people come into hospital quite a lot, and they've been on medications for years, and actually they're falling over, they can't swallow them, and all of these things. And we actually cut out so many of their medications when they come into hospital. So just try and keep, their medication for you. Do they still need this? Ask every time you go to see the GP. Do they still need all of these? Because, the less they can take, the better.
Can I just ask, when they go out from hospital, do you just give them the tablets they should be having, or do you give them a whole box full of all the rest that they brought in?
It varies.
My mum, actually.
It varies. It depends how good we are at the time, which ward they're on. It's very variable, I must admit. Sometimes, because they are their own tablets when they come in, some people have paid for their tablets, therefore it is their property, so they will go out, but sometimes the pharmacy will also ask, can I take these and destroy them? And we'll give you a new set that you just need for now. Depending on what you've gone in for, so if you go to a surgical ward for, say, just a surgical procedure, and you've taken all your tablets in, they may actually only prescribe on the discharge letter painkillers to cover you for the surgery, and may not take into account all the other health conditions that you've got. It's so variable. So it's about being on the ball, and it's very tricky. So I don't have an answer to it, and it is very variable.
It was stuff that she'd be given in hospital, and actually they conflicted with each other at the same time.
Okay. We do try and check with GPs what their current medications when they come in. So we do try and get because people will come in with a whole list and a whole bag full of tablets, and actually they're only taking 3 of them, but they've still got these from the year dot. So we will try and do a whole review of them, but it doesn't always happen. So things to expect from health professionals, and this is kind of where my heart sinks a bit, because I've written these things down that I would want to give, but I can't answer for all of my colleagues. So they should recognise you as a valuable part of the partnership. And I think in one of the documents that Louise talked about this morning, it talks about the triangle of care. And it's not a two-way thing between you and the professional with the person with dementia over here. It is a triangle, so the conversation should go all 3 ways. They should engage with you and keep you informed, so that you have all the information you need to provide the care you need to give. What I will add to that is, we don't always get the information maybe from the GPs. All of our IT systems don't talk to each other. So we're very much reliant on, letters going backwards and forwards, what you're telling us. The hospital system doesn't talk to the mental health system, which doesn't talk to the GP. So we're in no triangle of care at all. So sometimes we're very much in the dark about what's going on. So the GP tends to be the linchpin and have most of the information. If a person's coming to hospital, we will share back information about what's happened in hospital. And the mental health team should also write to the GP with diagnosis, that type of thing. But they don't all talk to each other, or the systems don't all talk to each other. So please be patient with us if we keep asking you the same questions when you come into hospital. We don't always get So healthcare professionals should provide you with any training that you need to take on tasks. And it may be tasks that you've started to take on without actually realising you're doing it. Things like moving and handling, you know, are you helping them to get up out of the chair and things like that. And you may not realise when you're doing it. So things like Suffolk Family Carers, with their training, you know, access that if you can. And if you can't, if the person is in hospital, we're sending them out with a piece of equipment, make sure you know what that equipment does, where to go for help, where to get new bits of equipment, if it breaks, what do I do, all of those things. And I fully understand that that's more pressure on you, but you know, if you've got that information and that knowledge, then you're forearmed and you can, you know, be better prepared once you're home. And I would say, you know, certainly myself in hospital and Maggie are more than welcome, you know, more than happy to come and see you and help you and make sure that you get the information that you need. Okay. Going back to the hospital, if the person is admitted to hospital, certainly in the West Suffolk, and I know they do it at Ipswich Hospital, we have a carer's pack to recognise you as a family carer. Again, it's a bit variable. We're trying to work very hard to get everyone to embrace it and to give it out. But if you know it's there, ask for it. So when you go in, say, I am a family carer, I want your pack, thank you very much. Give you a badge with a bit of, you know, some concessions and time out or restaurant and things like that. But it's also got some information in there, a bit about discharge planning, so questions that you can ask so that you're prepared for discharge, just some bits and pieces. And if there's anything you think that's missing from the pack, please let us know, because we're, you know, happy to update it and put more bits in. The last bit that people want to know about was continuing healthcare funding. Certainly if people are in hospital, we look at that. We do a continuing healthcare checklist and see if they trigger for the full assessment. If you feel that you need that assessment, even if you don't trigger on the checklist, we can still do that full assessment. That is then taken to what they call a decision support meeting with people like Rachel, who's our family carer, support worker, social worker, discharge planning team, and they go through it to see whether the person qualifies for continuing healthcare funding. And I must say, in my experience in the hospital, not many people do, so don't set your hopes on getting it. There's very tight kind of criteria for it. But if you want to appeal it, you can. And we will talk you through that if you have to go through that process while you're in hospital. And certainly you can get it if you're needing more care at home. If people's needs have changed, you're entitled to have a continuing healthcare assessment, and that would be done through social services. So that's my bit.
So if you